The observation that many patients who have normal systolic function still had dyspnea led to the suspicion if it is not the ejection of blood which is their problem, maybe it is the filling of the left ventricle which causes their symptoms. The importance of diastolic function lies in the fact that it is a very frequent cause of dyspnea, that it relates very well to prognosis, it is a marker of disease, it correlates with the severity of symptoms, and if we assess diastolic function, we can get very valuable clues as to how to treat the patients. There's a long list of different causes for diastolic dysfunction. Actually, almost every cardiac pathology somehow also affects diastolic function. We know that even with aging, we have a decrease in diastolic function, but very important and very commonly, it is associated with left ventricular hypertrophy, coronary artery disease, dilated cardiomyopathy, restrictive cardiomyopathy, hypertrophic cardiomyopathy, but again, very many other causes can also lead to diastolic dysfunction. Diastolic dysfunction or heart failure with normal ejection fraction is a very frequent finding. Approximately half of patients with heart failure have diastolic heart failure. This entity is common both in males and in females, and it increases with age. Patients with diastolic dysfunction have a poorer prognosis. If the E to E ratio is above 15, in other words, if left ventricular filling pressures are elevated, we have a poorer prognosis, poorer survival, opposed to patients who have an E to E ratio which is below 15. So what is the impact and the consequence of diastolic dysfunction, and why do these patients develop dyspnea? Well, the problem is that they have an elevation in left ventricular filling pressures. This translates to the atria, to the pulmonary veins, and eventually to the pulmonary circulation, and thereby leads to dyspnea and pulmonary hypertension. These patients can even develop right heart failure. So the main consequence is an elevation of left ventricular filling pressures. If we perform pressure measurements in these patients, we will find a pulmonary capillary wedge pressure above 12 millimeters mercury and an end diastolic pressure above 60 millimeters mercury. Those would be the cutoff values. The prognostic value of elevated filling pressures has been shown in many disease entities, ranging from acute myocardial infarction, cardiomyopathy, hypertrophic cardiomyopathy, valvular heart disease, and atrial fibrillation. Finally, just a word of caution. Heart failure with normal ejection fraction does not necessarily mean that the patient has diastolic dysfunction. Very often patients have normal ejection fraction but subclinical forms of systolic dysfunction. We know from studies which investigate myocardial mechanics that patients can have normal ejection fraction, but that, for example, longitudinal but systolic contraction is already disturbed. So probably the better definition is subclinical systolic dysfunction, which very often also involves diastolic dysfunction. This is an example. Here we have a patient who has severe left ventricular hypertrophy, as you can see, and normal or even hyperdynamic left ventricular function. However, on the right here you see a strain analysis which investigates longitudinal contraction, so contraction in this direction, and you can see the values are very low. Normally you would expect values above, I would say, minus 14 or 15%. Here the values are much lower, which shows that the patient already has significantly disturbed systolic function. So ejection fraction alone is not systolic function. Keep this in mind when you investigate patients for diastolic function. Because diastolic dysfunction so nicely reflects the severity of symptoms and also the prognosis, it should obviously be performed in every pathology. However, because you might also detect a problem you might not see otherwise, it should be performed in all patients. Sometimes, with the help of diastolic dysfunctional assessment, you might even detect a disease you might not see otherwise.